So hello and welcome everyone. Thank you for joining us. My name is Hitasha Rupani. I am a respiratory consultant. I work in Southampton and I've really worked with a great bunch of colleagues in the Accelerated Access Collaborative for the last year, and I'm so pleased that you're all here to be part of this webinar that we've put together. Hannah, can you go to the next slide, please? And so this, for the next sort of 45 minutes, we'll be talking to you about identifying and managing uncontrolled asthma. So I'm just going to wait to get to the next slide. Oh, maybe not. Okay, so yes, we're going to talk about identifying and managing uncontrolled asthma. And I wanted to introduce you to our speakers, who are two great people that I've got to know over the last year. Firstly is Beverly Bostock, who is the asthma lead for the Association of Respiratory Nurse Specialists. She also sits on the PCRS Policy Forum. She is an integral part of the Accelerated Access Collaborative. She also manages to squeeze in some work as an advanced nurse practitioner at the Mann Cottage Surgery, and is also the PCN nurse coordinator for Hereford. So really, she is an all-in-one asthma lead. And I'm so pleased that she's going to be talking to us, along with Clare Adams, who has also had great input into the AAC over the last year. And just as an introduction, Clare runs the respiratory advice service for Tees Valley CCG. She's also the respiratory clinical need for Tees Valley CCG. And in addition to all of that, squeezes in a lot of clinical work in terms of triaging patients with uncontrolled asthma and identifying those that need appropriate referral. So you're in the best of hands. And if you go to the next slide, please, Hannah. So just a little bit of housekeeping. We have some opportunities during the webinar today for some feedback and for you to put in some sort of answers to some poll questions. You can do that through 3 different routes. Before we get to that, just if you have any questions, they can go in the Q&A box, please. And then my colleague Gonya and I will go through those questions, and we can ask them either during the session or at the very end of the session. That would be preferable, because you will then have, you'll know what's coming through. And there's a Q&A box at the bottom of your screen, so you know where to go. Next slide, please. And really today, I'm hoping and I'm sure that you will go away from this sort of getting a much better understanding of what we mean by uncontrolled asthma, difficult to treat asthma, and severe asthma, and you'll sort of understand why it's really important to have sort of early identification of uncontrolled asthma. You'll get a better understanding of the treatment pathway, and then have some insight into what sort of specialist asthma centers can offer, and a really brief introduction on biologics. But really, I want you to get away from sort of understanding the whole patient pathway from if they have uncontrolled asthma to the severe asthma clinic. So the next slide, please. So this is where we can have some poll questions. There's 3 ways you can interact with us. So you can go to the website, and there's the link there, and you enter the code. Or if you have your phone in front of you now, you can go to scan the QR code, and that'll take you to where you can answer the questions, or you can open the link that's there. Just to also say that the webinar is going to be recorded and will be available on a link after we've sort of been through it, and it'll be on the AAC website and the Oxford AHSN website. And any questions that we're unable to answer today, because I'm sure we're going to have lots of questions, we will go through them. So we will be answers available that'll go along with the webinar link. So everything is going to be answered. So please do send us your questions. We'll do as much as we can today, and then the rest will email through as a link after the webinar. And I am going to leave it there and hand over to our speakers.
Thank you so much, Hitasha. So we thought we'd test the Mentimeter first. If you haven't loaded it up, really the easiest way to do it is actually to shine your phone at the QR code. It takes you straight to the questions. But if you do go through menti.com, then, oh look, you're already doing it. Cool, blimey, you're well ahead of the game. You do need to use that code that's there at the top of the screen there. So you're already answering the questions, and we were talking about this before we started the webinar, about how confident people are at identifying severe asthma. And we know that the various areas of the country have asked clinicians how they feel about this. And the important thing to tell you guys is that nobody knows what you've said. So nobody will be making any judgments on your answer. But hopefully it's reassuring for a lot of you to see that, the majority of you are saying that you're not at all confident. Well, you have a little bit of confidence around the topic. That's why you're here, quite frankly. So it makes sense to come along and find out more about it. And what we've tried to do with this session is make it very much about the beginning of the process of looking at potential severe asthma. So that's not all that we're addressing in this webinar today. We are looking at those patients who are not well controlled. So severe asthma, as you will see, is different potentially from uncontrolled asthma. And that's the sort of areas that we'll be covering. So it's very much about you guys who don't feel confident, where this is not the bread and butter of your work. But what's really important is to recognize that for those of us who are seeing patients with asthma, we really need to be aware of anything that might indicate a possible case of uncontrolled or difficult severe asthma, and manage them appropriately, refer them appropriately. So for you guys who are feeling very or extremely confident, all power to you for joining us today, because hopefully it will just reinforce what you already know. It will help you to understand that there are many colleagues out there who do not feel as confident, so we need to share the knowledge. But also there may be an element of you don't know what you don't know until you know it, and that's why you've joined us today. So you are all very, very welcome, and thank you for answering that question. So what sort of problems have we got? If we talk about why asthma is a problem and why uncontrolled asthma is a problem, these are the stats that we might be thinking of, but I'd encourage you guys to think about the area where you work. So that might be the geographical area that you work in, or it might be the area of healthcare that you work in. So is your prevalence perhaps higher than the normal level of prevalence? Do you know how many people are actually receiving treatment for asthma within your area of practice? I always think when we look at big figures like this, 5.4 million people receiving asthma treatment in the UK, that's important to know. But actually, how does that translate into the area that you work in? What does that mean for you as a clinician supporting people living with asthma? And if we looked at the responses to the Asthma UK survey that asked people about their asthma, 81% of them saying that their asthma was poorly controlled. Now, it's really, really important to recognise the numbers that were actually included in that survey. And also, if we're going to be scientific about it, to also recognise that this is a self-selecting group for people who chose to answer the survey. And they may well have answered the survey because they were not well controlled. That was one of the reasons why they decided to respond. But I think we need to be very, very clear that there is still a huge burden of asthma out there. And there are a lot of people who in reality or by perception feel that their asthma is poorly controlled. And that should not be the case these days. We have so many interventions that we know can improve asthma management, and they're all at our disposal. We just need to use them properly and work with patients in a therapeutic alliance to ensure that we get the most out of their care. We do not need these people being admitted to hospital. We know, look at that, 93,000 hospital admissions, and the vast majority of them are preventable. So why are we not preventing them? What's going wrong along the way? And I try not to think too much about money. You can ask my husband, he will confirm that fact, but that is a huge amount of money there. And this was 2011 to 12. Imagine how things have changed in the last 10 years. The pandemic, of course, impacting on asthma exacerbations, although not always necessarily in the way that we might have expected it to, but £91 million spent on hospital episodes. And again, thinking about those patients that really didn't need to have that admission, that did not need to be admitted, did not need to be in intensive care. So broadly speaking, beyond those very, very big figures, just think about those patients with poorly controlled asthma who just can't get on with their day-to-day life. And actually, when we're thinking about the financial side of things, it's important. When we think about these big numbers, it's important. But actually, if you've got a patient with asthma who cannot get to school or cannot do their job because their asthma symptoms are not well controlled, that's really worrying. So I mentioned uncontrolled asthma or poorly controlled asthma versus difficult to treat asthma versus severe asthma. And we have them here as a sort of, stepwise approach. I think it's important to recognize that we're not saying that uncontrolled asthma is necessarily less important than severe asthma. But it is important to recognize where there are different approaches that are going to be more effective with the individual. So with that patient who has uncontrolled or poorly controlled asthma, they are still symptomatic from their asthma and they may well be having frequent exacerbations. And any patient having an asthma exacerbation, that's a red flag. Even one is a red flag, although we tend to talk about two as being a significantly important red flag. We should just not be seeing these exacerbations. So we have to think about why that's happening. Then we have to think about difficult to treat asthma. So we've really tried to manage this asthma effectively using often quite high doses of medication, but the patient is still not responding to that medication. And there may be a range of reasons why that's happening. But within that group, there is this subset of people who have severe asthma, which means that in spite of maximal therapy, which they are taking, they are still symptomatic. They still have uncontrolled symptoms. And you can imagine that having severe asthma has a huge impact on your quality of life and is therefore really important to address. All of these are really important to address. But severe asthma may be the one that we're less well equipped to recognize, particularly in primary care. And this is where I think we can make a huge difference. So why do people have uncontrolled asthma? I imagine that many of you are very familiar with a lot of these causes. And, we have to flag up things like incorrect inhaler technique. We know that if the medication doesn't get down there, it can't work. It's like giving a baby paracetamol on a fork. It will not work. No matter how good the drug is, it is not going to work. So it's really important that we teach, observe, reteach inhaler technique. It may well be that the patient isn't taking the medication, and we always talk about non-adherence being intentional or unintentional. So we need to sort of dig down and find out what's going on there. There may be psychological aspects that impact on somebody's asthma control. It may be that they're smoking, which is ill-advised with asthma, but we know that that can impact on how treatments work for that individual, particularly things like inhaled corticosteroids, and that may be linked to the concept of under-treatment. So if we're having somebody who smokes and has asthma, they may need a different level of treatment to see the advantages that we might see in lower doses with people who don't smoke. But even in those who don't smoke, it may be that we have patients on suboptimal doses of medication. That might be because the clinician isn't sure what the correct dose is, or the patient has decided to take it their way, which means they're not actually getting the medication they need. Really importantly is the fact that we may have misdiagnosed asthma. And we know that a significant proportion of people where their asthma is not responding to treatment turn out not to have asthma, which is a real concern. And, there is a lot out there about the importance of diagnosing correctly. We have to think about the tests, how we restart spirometry in primary care, how we make sure that we're implementing FeNO if we have access to it, and really ensuring that we got that diagnosis correct through history. We talk about the tests a lot, but history is one of the most important ways of ensuring that the diagnosis is correct. And don't forget that comorbid conditions can have a big impact on people with asthma. So things like rhinitis, things like reflux, problems with the larynx, all of those can be comorbid conditions that actually cause symptoms that complicate our management of asthma. So then those patients who are not well controlled end up potentially having oral corticosteroids. And we know that there are lots of complications associated with oral corticosteroids. If a patient needs them, if they're having an asthma attack, then it's absolutely appropriate to use them. But the point is really that we shouldn't need to use them. So the fact that a patient has ended up on a course of oral corticosteroids, that's a failure really of recognizing when that asthma attack is approaching and maybe stepping in a little bit earlier to do something right. But also, when the patient gets to the point where they need the oral corticosteroids, we are going to do our best with respect to the asthma attack, but look at the complications that are associated with oral corticosteroid use and overuse. The more courses that people have, the higher their risk of these complications. So I think we need to think very, very carefully about when we prescribe them, recognizing that if the need is there, we need to respond to that need, but actually going back and saying, how did we end up with having to use oral corticosteroids in those patients? So when we're looking at severe asthma, we need to recognize, as we said, that this is a subset of patients, but around 3.7% of people with asthma have severe asthma. So again, think about where you work, think about the prevalence of asthma, think about how many patients you should have on your asthma register, and then consider that around 3.7% of those patients will have severe asthma. So do your figures match? Have you a register of your severe asthma patients? Do you know who they are and how they're treated? Do you know what your role is if you work in primary care to support those patients with severe asthma? Because if they don't get the right support between us in primary care, in secondary care, and in severe asthma centres, these individuals are going to end up using a lot of healthcare resource and are basically going to be feeling really pretty rotten with their asthma. So it would be nice to bring this to life really now, I think, Claire. And I know you've got a case study for us, which might help people to recognise maybe patients in their own areas of practice that sound similar.
Yeah, thanks, Bev. Absolutely. So following on from that, it's lovely to be here, by the way. And following on from that, we'd like you to meet Sarah. So Sarah's 34, and I'm sure many of you can identify with what Sarah's going to tell you in clinic. So she's come along to practice with worsening symptoms, and she's had her third asthma attack in a year. We're going to assume that she hasn't been admitted this time through any of her exacerbations. She was treated with oral steroids on all 3 occasions. What I find in practice, and I'm sure many of you can identify with this, is obviously oral steroids is absolutely the right treatment for acute asthma. They're often prescribed alongside antibiotics, but there's rarely cases of acute asthma that need antibiotics. But some practices, it tends to go hand in hand, and it really shouldn't. Obviously, if there's infective evidence of an exacerbation, then absolutely the patient might need antibiotics, but oral steroids is obviously first-line treatment for acute asthma, unless there's any other clinical indication that they need the antibiotics. So she's telling you that her sleep's disturbed by asthma, and she's getting wheezy whilst playing netball with her local club, and it didn't happen in the past with her. She's got chronic rhinitis, and she feels anxious on occasion as well. She's ordered 6 blue inhalers in the past 6 months. So when we kind of think about how many inhalers is all right to order in the past year, well, we know patients stockpile them. We know, the issue of over ordering and the pharmacies, ordering without asking patients should be gone now. That should be gone within the last year. So patients have to physically order their medications in primary care, but we do know some patients over-order medications. We have the chaos of households ordering for other people who don't pay for prescriptions. I think there's already something come up in the chat about prescription costs, and we know that's an issue for many people, and it's inequitable from that point of view for patients. But in this scenario, and following that the fact that she's had 3 exacerbations, we're going to assume that Sarah's needed all of those SABA and used all of those SABAs. And really anything more than 2 in the past year is really too many. It's a marker of poor control. 3 times a week or more, as we all know, I'm sure, is a marker of that poor control, and is a kind of a red flag for future exacerbations and poor control. So we really need to kind of understand, when we're talking to somebody like Sarah, the context of that use and the context of her symptoms. And like Bev was saying, we really need to get to grips with, has she got the right diagnosis? It's up to 30% of patients on our primary disease registers may not have asthma. And this is why NICE, I suppose, are trying to make the tests for it more objective, which is why we're seeing spirometry coming in at the point of diagnosis, which is why we're seeing FeNO there, as well as obviously peak flow. And we need 2 of those tests to confirm the accuracy. So we're going to revisit all of that. Looking for diagnostic confirmation, like I say, we need to look back in records. So obviously taking a history at the point of that presentation with Sarah, but reviewing her history at the point of where the asthma code first occurred, because in primary care, we do have that advantage of kind of looking back and doing a search I'm on system 1, so going into the new journal and looking back at the first occurrence of that code and looking for evidence of whether there was some evidence of spirometry or peak flow diurnal variation. You're unlikely to see obviously FeNO in the past, because that's fairly a new thing that's coming into primary care, and obviously it's not going to be in every primary care GP practice, but more in a hub scenario. So yeah, looking for that evidence of that diagnosis in Sarah's record, and obviously the features, traits, characteristics that fit with what we know is a positive history and high probability of asthma, and making sure that you believe that that's what she's been presenting with is really, really important. So looking at do we need to assess the fact that she's got higher exacerbation risk? Well, of course we do, and Sarah's got high exacerbation risk factors. She's had more than 2 exacerbations in the past year. She's had 3. She hasn't had a hospitalisation, but that's obviously defined as a severe asthma episode. So that in itself, if she'd only had 1 exacerbation, but that was a hospital admission, she's obviously got a significant risk factor for future exacerbations. We've already said that she's requested more than 6 blue inhalers in the past year, so she definitely is a candidate for reviewing everything in the context of her management, in the diagnosis, to see where we go from here. So one of the ways that we can assess Sarah's current control, and obviously we know she's presenting with poor control, is the RCP3 questions. So the RCP3 questions has been embedded within QOF for several years now, and added to that, which obviously asks for activity limitation, sleeping, and daytime symptoms as well. So obviously they are yes and no answers, but if we can go to the next slide, we can see that the asthma control test gives that in a lot more detail. So we get to see the reliever use. Now, I couldn't run a clinic without my ACT score. It's how I start my consultation. So the respiratory advice service that I'm running, which is above practice level at the minute, it serves 80 practices across my locality. This is how we start our asthma consultations. It very quickly lets you see where the issues are with patients with their asthma. The RCP3 questions are embedded within it, but it also obviously asks about, the 4th question asks about SABA use and the frequency of that SABA use. And then it asks about the patient's perception of obviously their control over the past 4 weeks. And that's always a really interesting one, isn't it? Because I find a lot of patients might be scoring low, so 3 or less on all 4 questions, the first 4 questions. By the time they get to question 5, they'll say I'm completely controlled. So their perception of good control and our perception of good control doesn't always correlate. So that's really important in terms of the way we talk to patients, in terms of asking what they understand about asthma. It really is the inroad in terms of that shared decision-making process really with our patients, in the context of, do you understand what asthma is? And this is perhaps where we get our lung models out, or if we haven't got the lung models, you know, because the reps don't supply them anymore, we go online and we find photos of what a you know, a poor controlled asthma airway looks like versus, you know, a successfully treated asthma airway. And it really, giving somebody that visual stimuli can really help change how they perceive things, and therefore can change their management and how they want to manage themselves. But this score really is, because it gives us a numeric, it's something really tangible to work with the patient. So Sarah will have, she'll have a score of way less than 20 because she's coming to a point of really poor control. So it's an opportunity to really unpick what's causing her symptoms. So this can be used obviously when you've changed medication. It can be also used as a way to de-escalate somebody. So we use it as a tool if somebody scores below 20 to want to think about escalating somebody's medication. And it might not always be pharmacological interventions that we need to make. We can use it if somebody's really well controlled. So if they've got a score of 25 and they're on high dose ICS and they've never exacerbated, it's a tool that helps support reduction in ICS as well in some patients. Now, obviously, we're talking about severe asthma today. So the patients that we're going to be talking about, we're going to expect to have low suboptimal scores. So it's really important that after somebody's had oral steroids as well, that we think about what are the processes for reviewing those patients, because I do know across my locality, I've got a regional lead role as well. So right across my region in the northeastern Cumbria, there's so much variation in terms of how many patients are reviewed in practice after even just one course of oral steroids. Because like Bev said, even one course is concerning and it's a red flag. So we need to think about in your own practice, you know, what is the process? Does the GP or the nurse practitioner, because they're the usual clinicians who see people for oral steroids and administer the oral steroids, see people, do they signpost back to the asthma nurse in practice? If that's you, do you get to see those people? Even if it's a minimum of a phone call, we need processes at practice level so that we're identifying these patients. I had a patient on Monday that had 7 courses of oral steroids in the past year, but nobody had followed that patient up after any of those courses. So this is still not right, and this is what we need to work on. And like we've heard from Sarah, she's already had 3 courses by now. So this is a fantastic tool to measure success, but also help you titrate and control as well. Okay. So we've already said Sarah is at risk of exacerbating. So it could be that she's on inadequate ICS. It could be that she's not on the right dose. Inhaler technique has to come in there, obviously. You know, if she's got a high, what was a bronchodilator reversibility, what's a blood eosinophil level, because anything at above 0.3 and especially above 0.4 means she's got potentially a treatable trait, and that Bev's going to come on to that later on. Her high SABA use, we've already said, is a red flag. It's not ethical to say to a patient you can't have a blue inhaler, even if despite overuse, you know, but it's not medically legally responsible of us as clinicians to keep dishing it out the door unchallenged. We need to be identifying these patients, and we need the opportunity to review patients as well. We've got to consider psychological and socioeconomic problems, and questioning Sarah about her anxiety levels is going to be really important, because she's highlighted that she can get anxious, and we do know that that can drive over SABA use, because people think they're helping themselves, but actually it's counterintuitive, because we know that, you know, they have tachypnea, and, you know, they can feel shaky if they're having excess SABA, which is going to drive that anxiety further. And I spend a lot of time talking to patients about that issue. We've got tools there to assess anxiety. Obviously, we've got GAD-7. I find the Nijmegen questionnaire really useful if I'm trying to unpick some hyperventilation and dysfunctional breathing. I find that really useful to unpick. It doesn't give me the absolute answer, it's just a tool, but it's to be used in the context of everything else that you're hearing from that patient. And obviously another risk factor exacerbating somebody's low FEV1. Now, with the advent of COVID and asthma, spirometry never was an annual thing, obviously, so we don't in primary care measure spirometry on a regular basis anyway, even without COVID. But obviously, if somebody's got low FEV1, they're often under secondary care if they've already got poorly controlled asthma anyway. So these are all risk factors that are really, really important to consider. We've mentioned inhaler technique, and actually it won't be surprising to this audience, I'm sure, that only 15% of patients use MDIs correctly. And there's all sorts of wacky things goes on, isn't there, with inhalers. People forget to take the cap off, they squirt it on the dog because they were once told they were allergic to dogs. They think that, you know, it sounds ridiculous, but ridiculous things happen. Then we've got the critical errors, you know, people double banging the inhaler rather than waiting the 30 seconds at least in between, and not coordinating. So there's all sorts of chaos associated with MDIs. Correct inhaler technique was only found in 16% of cases with healthcare professionals, and we've got another slide in a minute to quantify that as well. And inhaler technique has been shown to deteriorate as early as 4 weeks after optimization from a healthcare professional. So that's somebody giving a really good demonstration, and actually it's, you know, they'll forget what they've been told. So using resources like Right Breathe, I'm sure you've all heard of Right Breathe. We've got a resources page at the end of this webinar, and that's going to be shared as well, but that's one of the resources that are included. So if you haven't got Right Breathe in your lives, you definitely need it, and you can signpost your patients to that. I'm constantly sending links out on inhaler technique, Right Breathe links through AccuRx to patients now. It's really important to you know, reinforce that every single time you see a patient and every time you pick up the phone, especially after an exacerbation. It's so important. It's so basic, but it's really, really important. Okay. And this study, which is a few years old now, was conducted over primary care and hospitals, and it included pharmacists, doctors and nurses. And what it demonstrated is that 70% of us as healthcare professionals were doing it wrong. So like I said, we all definitely need Right Breathes in our lives, because that talks about, obviously it shows, it's got a video, it's got every inhaler in the world on, and it shows you a correct technique for every single video. The UK Inhaler Group as well have some really good competency documents. So if you're wanting to do a piece of work in your practice or over a PCN where you can really kind of validate everybody's competencies, that's going to be a really useful thing as well for the staff and for patients, because like I say, it's a really, really basic thing, but it's one of the most important things. Okay. So I've kind of alluded to this a little bit. So we need to think about Sarah as a whole person. She isn't just a set of lungs walking through the door who has a diagnosis of asthma. So let's say we believe that diagnosis of asthma, we've got to think what else can be going on, what could be contributing to a comorbid. I've just mentioned from Monday that I told you to have 7 courses of steroids. She is getting a secondary care severe asthma referral actually, because she's had so many courses and she's maximally treated. But she's also got a coma and steroid courses. So, and she's on methotrexate as well. So I'm suspecting that methotrexate is potentially causing some problems, but she also needs that severe asthma assessment alongside that as well. So she's a really complex patient. And this is the issue, we're coming across more and more complexities with our patients. But there's obviously basic comorbidities that you definitely need to consider. Reflux is a really common thing that I come across in patients who tell me they cough a lot. And that makes them trigger to use their blue inhaler. Actually, it doesn't help the reflux obviously, but they think they're doing something to help themselves. So reflux, postnasal drip. We've already mentioned that Sarah has a postnasal drip, so treating the upper airway we know improves asthma control as well. So it's one whole system that's all linked, so we need to treat the whole airway really. We know that like other medication like beta blockers and even things like ACEs obviously can cause coughing, which again, the patient may be triggering them to pick up the blue inhaler as well. I'm having many conversations with patients patients who have become deconditioned through inactivity over the COVID 2-year period. I know obviously in the last kind of 8 months, 9 months or so, we've been let out more, but people have put weight on. And there was somebody I spoke to not so long ago, have a BMI and asthma strongly linked, and that worsens control. We need to have those conversations about lifestyle as well. Okay. So adherence alongside inhaler technique is obviously really, really important. And again, in primary care, we've got the advantage of kind of looking through the pickup rates on prescriptions and obviously challenging that. And sometimes patients are using empty inhalers for a long time before, you know, they're adamant that they're picking things up, but they're not. But then it's often empty inhalers that people are using. So counting that and knowing, you know, that's sometimes a challenge, because it's knowing things like if somebody's on Clenil, for example, it lasts for 50 days. Whereas if they're on something like Relvar, it lasts for a month. Do you know what I mean? So we have to know how long something should be lasting, and then kind of calculate whether they are adherent. And then it's one thing picking it up, but it's another thing whether they've actually taken it. So we know that adherence to inhaled corticosteroids is less than 50%, and that was certainly in the NRAD and the National Review of Asthma Deaths Adherence. And I think as we go into the future, and there's more and more inhalers that are coming onto the market that have that smart technology, so that might link to apps that will really help us understand, you know, the adherence rates as well. Okay. So really, really important thing. And again, this is another really important recommendation that came out of the National Review of Asthma Death Report. It was published back in 2014, but it remains so important. In that study, only 23% of patients who died had personal asthma action plans, or PAPs. So, you know, everybody with asthma, children and adults, really need a personalised asthma action plan. You know, our consultations can be the cleverest in the world. We've told them some really good information, but life's busy. They'll walk out of that door and they'll forget what that lovely nurse said to them. They'll forget what that lovely GP said to them. And, you know, it sounds ridiculous to us, but, you know, things like the patient remembers that you said it was 10 puffs of the brown inhaler that had to puff into that thing. Well, if that's not written down that you'd said 10 puffs of the blue, silly things happen like that. We need to make sure it's written down. And this is why it's important. We don't, like Bev said, we don't want these patients going to hospital. We can affect a 62% decline in prednisolone, 60% decline in emergency visits, and 51% in exacerbations. You're 4 times less likely to need admission if you've got an asthma action plan. We need to take photos of them as well, and have them on our phone. Okay, next one, because I think this is going to show us. Yeah, so this is the Asthma UK asthma plan, and actually I'm calling them Asthma UK. They've just rebranded themselves yesterday, Asthma and Lung UK. So do go on and have a look at their website. They've got fantastic resources on there, and the asthma plans are there. And what they do as well is, I know there's very little confidence in some clinicians in terms of how to write an action plan and how to do that in terms of peak flow calculations. It's often a barrier for writing a plan for a patient, because, you know, whatever we put down is in writing, and, you know, have I done it right? So Asthma and Lung UK do some guidelines for how to calculate peak flow if you are confident to kind of do that calculation within the different zones. But if I'm being honest, there's not many patients that I speak to know their best peak flow. So I'm often disregarding the peak flow bit unless they've got good control, because the only time we can know whether somebody's got a best peak flow is when they're completely stable with their asthma. And then we can start calculating the drops from, you know, in terms of what to identify. The symptoms are obviously there for us to see in terms of deterioration. And like I say, if we recommend that, like when you send it through AccuRx, or even if you've printed it, it's not practical for people to carry pieces of paper around with them. So get them to take a photo on the phone. For children, make sure the school has sent a copy as well, or you know, empower the patients to send the school a copy as well. Okay. So I think I've said some of this. So yeah, check it. It needs checking every time we see it, and especially if there's been a treatment change, it needs to be an obvious location, like I say, on the phone, and check it all the time, and remind people of resources like, say, Allergy UK, and the British Society of Allergy and Clinical Immunology as well is a really, really good resource to use, and really good resource for you guys as clinicians, especially because she's got allergic rhinitis. So it really sets out some nice guidelines within that website as well. Okay. So she needs a PAP. We need to write that for her. We need to make sure treatment's optimised. We need to address the lifestyle change. We've already mentioned anxiety and addressing that and measuring that. Encouraging a regular exercise. What we don't want is Sarah to not engage in doing netball because she's got asthma. You know, people shouldn't have to have their activity affected, but obviously we have got a cohort of patients, and Sarah might be one of those, we don't know, that actually is in the 3.7% that has severe asthma. So until she's, you know, that's been identified and she's been treated successfully, and we're going to come on to that in a while, then she might be restricted because, you know, obviously we've got patients in primary care, and like Sarah might be one of them where she's fully optimised but still, despite that, has poor control. Everybody needs to eat a healthy, balanced diet, and obviously that applies to our asthma patients as well. Smoking cessation, obviously so important at every opportunity, and we need to address the vaping issue as well. So we need to use read codes in practice. We need it for public health kind of information as well, but there's codes in your practice for user of electronic cigarette, ex-user of electronic cigarette, so we need to know vaping status as well as smoking, and obviously illicit stuff that she might be smoking as well. So we've optimized her inhaler technique, we've checked her adherence, she's doing well on both things, however her symptoms persist. So what is the next thing for her? What do we need to do to increase her treatment? So we've got the BTS guidelines is the thing that we mainly follow, I think, and certainly my region. We've got NICE guidelines nationally, and we've got BTS guidelines nationally, but certainly my region, whole of my region, favour BTS. Now BTS and NICE are coming together, and hopefully we'll get a joint guideline published sometime next year, I believe that is. So at the minute we're talking about, you know, we're on an ICS obviously in all asthma suspected patients. We've got MART therapy as an option. So Sarah may have already been on a MART regime. After the MART regime, you could obviously give MART regime or a fixed dose regime. I find MART is really, really useful for those patients who are really dependent on their blue inhaler, because often there is compliance issues with the steroid. So it's a real important way of kind of ensuring that they're having the steroid, they're having their you know, their reliever in a long-acting version. And obviously there's different MART kind of limitations depending on which MART regime you're on. For example, if it's Foster, it's maximum of 8, Symbicort, it's maximum of 12 puffs in a day. But obviously we've got to bear in mind that within the asthma control test, any reliever use, so remember when you go on to that question 4 and it asks about blue inhaler use, if they're on a MART regime, you need to apply that same question to the MART relief, because any relief is a marker of poor control, even if that's in a MART regime. So after medium dose ICS, whether it's fixed dose or MART, we've got the opportunity to add in Montelukast or Lammers at that point. If they're still having poor control despite all of that additional treatment, then obviously we've got high dose, and we now have high dose in triple as well, licensed in adults. So look at your local guidelines, think about what she's on. If you're thinking of starting a high dose, you really need to be referring to secondary care. Now, patients who are already on historical high dose, that doesn't mean they necessarily need a secondary care referral, because in primary care we know that many patients are over medicated. Some patients need it, some patients don't, so clinically we need to assess that. Okay, so quick question before we move on. So does Sarah, do you think, have uncontrolled, difficult to treat or severe asthma? All vote now. Oh, it's starting to work. There's something going on. Oh, it's balls this time. It was graphs. That's a bit clever. Oh, the numbers are going up. Okay, okay. So yeah, so most of you are going with uncontrolled. We've got a few in the difficult to treat and a tiny amount in the severe asthma. So she's definitely got uncontrolled asthma right now, hasn't she? Regardless of whether it's difficult or severe, she's not controlled, and that's not all right. And we've excluded different comorbidities, and we just think it's asthma. We need to understand what's going on with her. So difficult to treat, you know, if she's compliant and adherent with a medication, it's not necessarily difficult to treat. So she has a suspicion here. We've got an index of suspicion that really she might have severe asthma, but she's definitely uncontrolled as well. Okay, thank you. So when is a referral necessary? So Bev's going to cover this in a little bit more detail in a minute, but she's got signs, symptoms of severe asthma because she's maximally treated, she's compliant, she's got good inhaler technique. If we've got access to FeNO and eosinophil counts that are above 0.3 and certainly above 0.4, she's got what we call treatable traits there that absolutely need to be signposted. Okay, I'm going to stop talking now and pass to Bev.
Thank you so much. That was an amazing run through all of those really important points, Claire, and you guys in the audience. What incredible questions you're asking, and such great chat going on in the chat box as well. Don't forget, if you do have a question, it's best to stick it in the Q&A box so we make sure that we come to it. But the interaction going on in those conversations is just amazing. So really great support for each other. So this, what I'm going to run through now in the few minutes we've got left, because we do want to leave time for you to ask those questions. I'm going to run through some of the tools that we've got to support you to actually remember the patients that we should be referring on. So this is something that we came up through our work on this project, something called the HASTE tool. And what we wanted to say to you is make haste and refer. So these are your little, this is an aid memoir to help you to say, yeah, I've done that, I've checked that, yeah, that's okay, yeah, we've sorted that. Okay, at this point, this individual does need referring. So is the patient already on high intensity treatment at the high end of the treatment escalator? Are we sure that that patient is actually taking their medication, correct dose, correct frequency as prescribed, not their own version of it? So are they actually taking that medication? Have they had a severe exacerbation in the last year? So that means that they were hospitalized as a result of that exacerbation, or they've had 2 courses of oral corticosteroids in 12 months. So the severe exacerbations, steroids, that's what you're thinking about with the S. Technique. It's so basic, but it's so important. I was talking to colleagues the other day who reported that a patient turned up for an asthma review with their spacer, no meter dose inhaler, just the spacer, taking the spacer alone without an inhaler attached to it. So, you know, how important that people actually look at inhaler technique. Don't just take their word for it when they say they can do it. So is the inhaler technique correct? And also remembering that people do fall off the wagon. They'll do it right when you see them, but potentially they lose that technique as time goes on. So giving them the tools to be able to recheck and reminding them why it's important. And that's T. So E is then for excluding other conditions, the ones that we've already heard about. So, so haste, make haste, tick off those things, then refer. Because if we don't refer that patient into secondary care for assessment, then they're not going to get the referral on to tertiary care, to that severe asthma centre, where they may get treatment that is life-changing and potentially life-saving as well. You've also got the BCS sign guidelines with their referral criteria. And actually the work that we did with HASTE was based on a lot of the recommendations. Sure, we haven't covered everything. There are other things that we ought to be mindful of. But look at the BTS sign guidance on referrals. Look at the GINA guidelines. And we were talking about which guidelines to follow earlier. I'm a huge fan of GINA. absolutely huge fan of Gina. I'm a huge fan of Gina, and I'm a huge fan of the MART approach as well. So all the comments about maintenance and reliever therapy, for me, absolutely, I think it's really important that we've tried that with patients who may still be symptomatic despite their basic treatment. So get familiar with the recommendations in BTS Sign, get familiar with what Gina says, and just feel confident in that referral. Don't hesitate to refer. In fact, make haste and refer. We've also got another tool that you might be interested in, and that is on the next slide. If you want to pop that one, there we go. So the Spectra tool, this is an incredibly useful tool for you to interrogate your system and identify these patients. So this is something that's been endorsed by the programme that we've worked with NHS England. We've worked with the Accelerated Access Collaborative. We have developed this tool, and it is really, really helpful in trying to identify these patients. So it will look for those patients who are overusing their blue inhaler, look for the patients who've had courses of oral corticosteroids, and it will find them for you so that you can then be proactive at looking at managing them using the tools that we've already mentioned. So is there something that is obvious? Is there something that we can do to make sure that patient is better managed, or actually are these individuals ones who should be referred into secondary care for potential tertiary care assessment? So there's a website there you can see at the top of the mini screen there, www.suspectedsevereasthma.co.uk. You can get onto the website, have a look and see what it has to offer. There's support for you if you struggle with IT, as I do. I got support when I used it. But it is such an interesting tool when you've actually got the data there to look at and see what you're actually finding and identifying the patients that you didn't even know that needed that extra input. So highly recommend people having a look at the Spectra tool. There's also a link to a referral template that includes all of the things that we decided as a group were important. And Hitasha had huge input into this referral letter as somebody working in this field, what she would expect to see on a referral letter that would ensure that those patients were being referred appropriately. So, not rocket science, nothing on there that will surprise you, but it's all there as part of the Spectra tool as a referral template. So really excellent opportunity to refine the way that you refer. That's nice as well. Julie saying there that it's helpful for audits and CQC visits. That's always a good thing to bear in mind. And then we need to think about, what are they going to get when they get into that specialist asthma centre? Before they even get the consideration of the biologic, there will be huge multidisciplinary teams who can all impact on all of the areas that we've discussed today to improve outcomes. So it's not just a case of them going in to see the respiratory team, they're going in to see a whole range of individuals who can help that patient to optimize the control of their symptoms and comorbid conditions to get the best outcomes before we actually move on to the biologic therapies. And we have got a slide next that talks about which biologics might be used for the patients with specific types of inflammation. I do think that it's really important that we recognise in primary care, these are decisions that are made in secondary care. So the patient will be reviewed in secondary care and get the most appropriate treatment for them. And then what we need to consider is that how are we, with us working in primary care, those of you, I know a lot of you are actually working in secondary care. Those of you working in those specialist asthma centres, what do you want to see? How do you know that the biologic has worked? What can we expect from an appropriately prescribed biologic? And these figures speak for themselves, really, don't they? Asthma exacerbations reduced by 50%. And I've heard from patients who've gone on to biologics, and as I say, it's been life-changing for them. Plus, they're having the reduction in their steroid load, which is going to have holistic health benefits. But we do need to keep an eye on them. They do need to be reviewed. and they will get that multidisciplinary team review at a year as well. So they're not left to it. We are constantly reviewing them. But what about if we work in primary care? Where do we come in? Do we just let them go? Do we just ignore them because they're now under the care of that team? Absolutely not. We need to ensure that we go back to basics, that we give these patients the care that they deserve. And we know that some of them felt that they missed out on some of their care during the pandemic. We need to find out who these patients are and make sure we're supporting them. So working with the team in the specialist centre to optimize the care for that individual. So this is, I think, the most important part for those of us working in primary care. Work with our colleagues to get the best outcomes for our patients. So anyone, some of you have already voted on the last question by the looks of it. Would you like to say now at the end of that presentation, how confident are you that you could identify a case of severe asthma? And we're already, early days, but we're already seeing some improvements, a definite right shift on the graph there. Fabulous. So I think it's time for questions. Hitasha, Gronya, do you want to take over?
Yeah, brilliant, Bev. Thank you. Lots of fantastic questions coming through. I've just sort of cherry picked a couple because there's a sort of a few themes. One of them is around the personalised asthma action plans and asking about, lots of chat about how to manage exacerbations without using oral steroids. So how do you advise using the inhaled corticosteroid, and what if patients are on a MART, so maintenance and reliever therapy, so they're getting an ICS LABA? Would you like to answer a question there? It's a fantastic one from Penny.
Well, I'm happy to say that so there are some MART asthma action plans out there. They are available. So you can get them from a range of sources, including the pharmaceutical companies, some of them. I developed my own because I'm a bit like that. So I've got my own MART plan that I use with patients. But I think the most important thing to remember with MART is that the whole point of MART really is that it prevents the exacerbations. So, that's the key thing. Don't think, oh, well, should we use MART because we don't know what to do if they exacerbate? The whole point is, you should be reducing the risk of exacerbations. But I think the question about oral corticosteroids, we have to recognise when patients really, really do need them. We know there's evidence out there to say you can increase the ICS 4 or 5 times, but in reality, does that happen? And if you've got a patient who is poor technique is the cause of their exacerbation, then asking them to take more of that incorrectly probably only means they get the normal dose in the first place.
And of course, it depends what they're on as to whether you're allowed to increase it, because clearly if you're taking something like Relvar, which is once daily, we can't advise them to increase that. So it really isn't a blanket answer, which is why they need to be individualised, which is why, I would encourage you to kind of go, if you're not sure how to write them, go and update, sit in specialist clinics and use the Asthma UK resources. There's very few patients I give oral steroid rescue packs to within their management plan. They're only a tiny cohort, they're usually under secondary care already, but if we gave oral steroids as rescue packs, like would in COPD, then people would definitely overuse them. We need to be signposting early, I think.
I think that's fantastic advice. Thank you both. So on a sort of similar theme, this is a great question because it comes up quite a lot. If the patient doesn't have a sort of recorded peak flow, do you sort of, you're looking at the peak flow for the action plan, what would you use? Would you use from the chart based on their height and weight and gender? Is that the number you would use, or what number would you use to sort of set as their standard?
So the issue for this with me is that my best, I haven't got asthma, my best is 400. My predicted is 500. If you're using that for me, I'm poorly all the time, where somebody else my height, my age, her best might be 600. So, really we need best as the marker of what to use. And we can only know that when somebody's really got good control. So looking at the history of when they had an ACT score of more than 20, more towards 25, and they were well is a really good marker if they're doing a peak flow and they're well at that time to get the best and then calculate from the best. I'm very reluctant to do a predicted calculation in an asthma plan because, like I've just said, the two analogies there, it's not going to be accurate for that person.
I think you're absolutely right. It's certainly it's such a key issue that we almost set people up to fail if we put them on if we say that this is what you're aiming for and there's no chance they're going to get it. So I think that's fantastic advice. And another question, I genuinely don't know the answer to this. I barely look after my own children. I'm not going to look after anybody else's, but can you use an ACT or any of these questionnaires in children?
Yeah, there's a children's asthma control test that's validated from 4 years old. It's a great resource. It's a regional, to me, it's called Beat Asthma. They are trying to kind of get that out more on a national level as well. So Beat Asthma is led by Newcastle physicians, paediatrics, but they do get regional involvement. But like I say, they're really trying to launch that out. Obviously, Asthma UK is a fantastic resource anyway, but unfortunately, the asthma control tests are not embedded within Asthma UK. But Beat Asthma has them on for children as well. Really good resource.
Fantastic.
I might ask one of the questions that came up, and I think this is something that I do quite a lot in my practice, is confirm the diagnosis. And I think, Claire, you emphasise how it's really important to confirm that. And I feel like a detective. I go through all their previous sort of A&E admissions and I look at the actual notes. If anyone had any wheeze, I go back through primary care records. But if you had somebody in front of you that was given this label of asthma and you were a little bit suspicious that it might not be asthma or you wanted to confirm it, what steps would you take? Would you sort of reduce their treatment, or can you talk the audience through what you would do if you sat in that clinic in primary care trying to confirm that diagnosis?
I think it all comes down to the compliance thing as well, is whether they're compliant and you know, if there isn't any strong evidence backwards in the history, objective evidence, and they're not compliant, it is a kind of an opportunity, if there's no suspicion of asthma, to kind of even stop the treatment or stop it dead. If they're not compliant, then they're not been having it anyway. And especially if somebody's saying to me, well, I use an MDI but I don't use a spacer, and they've got poor compliance, they've probably got a very negligible amount going into their airways anyway, haven't they? So it depends on what, again, it's difficult to really answer that as a blanket answer. It depends in terms of what the patient's saying to you and the chaos that they're talking about, and you know, like I say, thinking about the other comorbidities as well. But yeah, if somebody's on high dose and you think, actually, I don't feel like this is asthma, then reducing that is always a useful thing to do first. And if you've got access to things like pheno, even better, you know, and I think more and more as we evolve our diagnostic hubs, I'm hoping in my area that we'll be able to kind of have access to the practices to review those patients with difficult asthma, where we're not maybe, you know, highly suspecting severe asthma, but actually there might be compliance issues. Somebody's on a high dose where they could come down, all sorts of things like that. So I think pheno is going to be really, really useful with patients like you're just talking about as well.
Beverly, can I just check with you? So when you were talking, first of all, in your first presentation, there was a lot of agreement with what you were saying around the rates of misdiagnosis and how easy it is to get the diagnosis not quite right, and concerns about prescription charges and things. So there's a lot of agreement with that. You also mentioned about oral corticosteroids and this idea that, you know, we overuse them. How do you think, as a healthcare community, we can work together to kind of, you know, make people more aware of the side effects and the problems associated with steroids, as well as understanding the benefits, which I think is clearly an acute exacerbation is different than kind of the routine use that we sometimes see?
I think it's a case of making sure that clinicians highlight this when they're talking about good asthma control, because if a patient needs oral corticosteroids, we don't want to be frightening them into possibly not taking them, but pointing out to them how important it is to avoid the use of oral corticosteroids, and, you know, the dose that we're giving compared to the minute dose that we give in comparison through an inhaled corticosteroid. You know, hopefully you get that joined up thinking from clinician to clinician and from clinician to patient or parent, because that's really important to consider, you know, when you're working with parents. that they're on board. Otherwise, again, that individual child is not necessarily going to get the treatment that they need. So I think going back to what Claire was saying about the little models that you can use, explaining to them that the reason that they need to use a bronchodilator is because their inflammation is not controlled, and that the treatment that we're talking about that's anti-inflammatory is in fact the inhaled corticosteroid. So it's a good point that Sally's made, though, about inhalers and cost. There are different studies out there, but there are certainly studies that say that making inhalers free does not impact on outcomes.
Yeah, I could echo that. I think the main message there is simplify their regime, give them something that they're going to be able to use and that they're willing to use and that fits in their daily life. And that's the best chance of improving adherence. And just wanted to bring back or sort of remind people what Beverly said, that we do have another webinar on adherence and how we can assess it and the importance of doing it, and how we can address non-adherence. So please do sign up for that. Courtney, have we got any more questions? I know people are still on the line and I know we're running late, but if there are questions, we're happy to go through if people want to stay and go through those.
Having said that, I think our hosts have just said that it's probably about time to to wrap up. But we did say that we will address all of these questions and there will be a link to them. So if you haven't had your question answered today, they will be those answers will be available when you have a look at the website, where we have the link to the talk for anybody who missed it today. So there we go. We've got the link there, so you can keep that and share it with your colleagues.
And there's also a module that reflects pretty much what this webinar has covered as a module, as a teaching module. So do go towards that as well. We cover a lot of very, very similar themes. And there's a lot of questions coming up about asthma diagnostics. And I would encourage you to go through sort of the NICE asthma diagnostic pathway and your local guidance for that. Got lots of thank yous coming through. Great. So thanks everyone for joining us. I really enjoyed this, and it looks like everyone else as well. Go back and look at the recording, look at our modules, join us again. We've got 2 more webinars coming up. And really we hope to enthuse the entire sort of national community to try and improve the care of our patients with asthma. So thank you.
Yeah, thanks everyone.
Thanks. Bye-bye.